Dr. Omar Akhter is our guest speaker. He is a medical doctor here in town. He is an internist and he has his own private practice in Cedar Park. It's right over there off of 1431 and 183A, kind of like behind Georgetown, something like that. And he focuses on hormonal health. He's trained in functional medicine and aims to improve chronic disease with a holistic approach in the community. Again, I met him probably over a year ago, and he's been a great resource. He is our guest speaker, so let's get him up.
Okay.
Did you already start that?
Yeah, I started.
Okay, perfect.
Okay, well, thank you, Celia. I appreciate that, and thank you for having me back because I did this last year and it was a lot of fun and good information. So, um, hypothyroidism and Hashimoto's is something I deal with a lot, and obviously it's very common, and so I love talking about it and hopefully get some good information out of this. So, the first thing is to understand how prevalent this is, and so just to give you an idea, around the world, around 5% of the world's population, about 380 million people around the world suffer from thyroid disease, some type of thyroid disease. And thyroid hormone like levothyroxine is the second most common prescribed medication in the entire world. So it goes to show you how significant of an issue this is. Now, in the US, about 20 million Americans have thyroid disease, and thyroid hormone is also the fourth most prescribed medication here in the US. So by a show of hands, how many of you know someone that's struggling with thyroid issues? Probably quite a few people. So it just goes to show you how important this is as a topic. So the first thing is to understand what are the symptoms of hypothyroidism that someone might struggle with. So there's fatigue, there's going to be constipation, weight gain, a decrease in metabolic rate. You can have a loss of outer third of eyebrows as well as general hair loss, slowing in the heart rate, brain fog and difficulty focusing, which is very common, depression, mental health, mood-related issues, and menstrual irregularities, and infertility. So all of these can be symptoms of hypothyroidism, and sometimes even when your labs are normal, you still have these symptoms, which is something we're going to discuss a bit later on. Now, just a little bit of basics. I don't want it to be too medical, but just a little bit of basics so we're all on the same page. A little bit of understanding how the thyroid works. So we have the TSH, which is the thyroid stimulating hormone, something that you guys might be familiar with on the blood work. So the thyroid stimulating hormone is basically a hormone that is released from the anterior pituitary gland in the brain. And it's what's stimulating the thyroid gland to produce thyroid hormone. So the thyroid gland is located in the neck. The TSH comes to the thyroid gland and it then produces the thyroid hormones. So you will produce T4 and T3. Those are your two thyroid hormones. You produce more T4 than T3, roughly about 80 to 90% of T4, and about 10 to 20% of T3. The T4 then will circulate around the body, and then it will eventually get converted into T3, which is the so-called active hormone. So T3 is the active hormone, and T4 is considered an inactive hormone. So that's important to know. So it's really the T3 and the free T3 that's doing all of the cellular effects of the thyroid hormone. So with this understanding, what is currently out there? What is the system that is applied? And I like to look at it like this, which is the current linear model that we have, which is that you have some symptoms or you go to your physician for your regular annual checkup. They'll do some very basic blood work, okay, like a CBC, a metabolic panel, lipids, and a TSH. And that's all they'll check. And they'll check the TSH, and if your TSH is high, they're going to put you on Synthroid or levothyroxine, and they will basically repeat the TSH every 6 to 12 months, and they just adjust the dosage that way. That's really the only model that's out there in the conventional system. And what they'll do is when you complain about other symptoms, the depression and menstrual irregularities and so on, they will use all these other medications to try to cope with those symptoms, the antidepressants, oral contraceptives, and so on. So this is the model out there, and I think this is certainly a model that most people realize is not working, and that's the reason for a lot of the frustration with the medical system. So the way it should be, as far as I'm concerned, is first of all, as far as testing goes, a much more nuanced and almost a 3D approach to testing, which is that we get an entire thyroid panel in addition to all the other blood work. So that includes a TSH, that includes a free T4, a free T3, a total T4 and T3 when needed, and then thyroid antibodies, which is going to be very important, that don't get checked a lot of times. So TPO antibodies are short for thyroid peroxidase antibodies. And then reverse T3 is another thing that doesn't get talked about much, which is like the brake pedal in the thyroid. So the first thing is a three-dimensional approach to testing. In addition to this, what's important is also symptoms. And I keep stressing this because a lot of times physicians are so blinded by the patient's symptoms and what the blood work is showing, that the patient is in front of them complaining about a whole list of symptoms, yet they'll see the blood work and they'll just go like, you're completely normal and fine. And I think the blood work paints a certain picture, but it's the overall symptoms are what's important as far as understanding and treating that patient goes. So that is an approach that I'm really for. Even if the blood work shows something, it's about what the patient in front of you is telling you. So now when we have hypothyroidism, it's important to realize that the most common cause of hypothyroidism is due to Hashimoto's, which is an autoimmunity, which is an autoimmune condition of the thyroid gland. And this happens to me a lot, where I'll get patients and they're on thyroid medication for years and years and years. And you ask them why they're on thyroid medication or why they're hypothyroid, and they have no clue. They have no idea, because nobody really dug into why they have hypothyroidism. And so it's important to understand that around 90%, 9 out of 10 cases, you're going to have Hashimoto's as the cause of hypothyroidism. It mostly affects women, but women are about 8 times greater risk than men, as most autoimmune conditions are. Women around, again, 20 to 60 is a broad range, but it's starting to affect women much, much earlier now than previously. And it's the most common autoimmune condition in the world, which makes it even more important for us to discuss. Now, how to diagnose it is very important. So the circulating antibodies, which is the thyroid peroxidase antibodies, is the best marker to diagnose Hashimoto's. And the diagnosis is quite simple. Unlike some of the other conditions like polycystic ovarian syndrome, Hashimoto's is either you have it or you don't. So either the thyroid peroxidase antibodies are positive or they're not. And that gives you a pretty good idea, because there are about 90%, 95% of cases where the in Hashimoto's have thyroid peroxidase antibodies. Thyroglobulin antibodies are another antibody that can be checked, and that's a little bit less sensitive, so about 60 to 80%, but still very important to check alongside a thyroid peroxidase. If you had to do one of the tests, you would maybe opt for a thyroid peroxidase, but thyroglobulin is still very important. So this is what something like that might look. So this is a patient's results, where you can see that if you just check the top line, you would just do the TSH, and you would see that the TSH is absolutely fine. So you would conclude that there isn't anything wrong from a thyroid perspective with this patient. What you would miss out then is you can see that the thyroid hormones themselves, the free T4, free T3, while they're quote unquote in range and considered normal in that sense, they're definitely towards the lower end of the range. And this is, for example, from a patient that has a lot of symptoms pertaining to the thyroid. So again, it's just a good example of where if you would just do the TSH, you'd end up missing out on quite a lot of information, as well as the fact that this patient has Hashimoto's, because the thyroid antibodies are clearly way, way above normal, and actually above 600 in this case. So this is what a typical panel should look like, just as a baseline. Meaning this is what you should get, not that I want this to look like it. So in looking at Hashimoto's, I try to explain to people that the linear approach to Hashimoto's, which is just focusing on thyroid hormone balance and the numbers, and ignoring Hashimoto's and that connection that it has to the thyroid and the rest of the body, is that linear approach just isn't working. So a lot of physicians will, even if there's Hashimoto's there, it doesn't change any part of their management, which is just not adequate. And that's why you have a lot of these patients that are ending up frustrated and don't know where to turn. So I like to look at it more like a complex web. because what I tell people is that it is a multi-system inflammatory condition. So it affects nearly all systems of the body. And this, when you hear this, this is very validating. If you have, for example, if you have Hashimoto's and you have brain fog, then you understand that the reason I'm having this symptom is because of inflammation in my brain. And so it's very validating to people, and people actually, patients don't think that they're crazy in that situation, which a lot of times they're told that it's all in your head, or they get a psychiatry referral or something like that. So I like to think of it as a complex web and a multi-system inflammatory condition. And this is how it's all connected to different systems. So you have a Hashimoto's in neurology web and a Hashimoto's in GI web, and that's why it, again, the conventional system is set up for specialists to just focus on one system, and when they do that, they're missing out on that person, that entire patient. And so when I see a patient, it's what are the neurological symptoms that you're having, what are the GI symptoms, what are the female hormone or male hormone imbalances you're having. And so that is very important when looking at it altogether. So I'll generally see three types of patients, and this is very important to be able to just from conceptually. So you'll have the patients that are completely new. This diagnosis is completely new to them. So they haven't seen a physician. They just started having symptoms. They got the diagnosis. These are patients that obviously there can be so much done to help them. You then have patients that have gone through more of the conventional care. They've seen their primary care physician. They've seen the endocrinologist. Not a lot of alternative care, and so they're still struggling with symptoms. Again, this is a category of patients that a lot can be done for as well. Probably the tougher area, the tougher group, is this third type of patient that has had the significant conventional and alternative care, yet they're still struggling with symptoms. But I do think that even with this group, there is a way to if we're very organized and systematic about the approach, we can still help them as well to address their symptoms. So now, how do we approach treatment for Hashimoto's and hypothyroidism? So I like to think of it like this pyramid that I made, which is basically that instead of, again, just thyroid hormone and finding that thyroid hormone balance, we have to start with a dietary foundation, because if you're struggling with a lot of Hashimoto's or hypothyroidism symptoms and we go straight up to the medications and your diet is full of ultra-processed foods, a lot of inflammatory foods, then you're not going to truly get better how we want you to get. So a lot of times the diet is going to be the first step, and it's probably, it's not an easy step, but it's definitely, in terms of just low cost and an easy, just in terms of just an overall, that should always be the first approach. So diet comes first, and we'll talk about that in a little bit. Lifestyle is very important because, again, something that isn't appreciated so much out there is that your stress levels, your sleep, your exercise, your relationships, all of that, even your spiritual connections, all of that matter as far as your immune system and your physical body goes. And again, that's something that conventional medicine does not address because it isn't set up that way. And then we go on to trying supplements, and I mentioned supplements first because, again, there's always a more natural and holistic approach, sometimes an herbal approach that you can take, which tends to have, it was better tolerated with less side effects, and I tend to try to use that first, and then there's always medications that are needed at different times. So when we talk about diet, I think it's good to look at it in a way, what are the foods we can remove that are more inflammatory, and what are some of the modifications that we can make? So on the left side, I put restrictions because gluten and dairy just are at the top of the list as far as the most inflammatory foods go in regards to Hashimoto's. Now, I'm not a believer that every single person has to come off of gluten and not consume gluten, but I do think that the research on gluten and Hashimoto's is very clear because gluten has something called molecular mimicry with Hashimoto's, which means that the gluten molecule is very similar to the thyroid molecule. So when you do consume gluten and you have Hashimoto's, the immune system mounts a reaction against that. And so because they're so similar looking, the thyroid, as an innocent bystander, gets impacted by that. And so a lot of patients, when they remove gluten and dairy, can certainly feel much better, and it's always a really good approach to take. Now, that doesn't mean you have to be off of gluten your entire life. Some patients are off of it and they don't feel too much different, so they may be able to tolerate it better, but for some patients, it can be an entirely a game changer. And then we come to a little bit more levels of different things that can be removed if you're going more towards removing grains in a more paleo, anti-inflammatory diet. Some patients initially need that. Again, the goal with diet is always to not be restrictive, right? We don't want to aim for that. We want to be as liberal in the diet as possible. But there is that understanding that sometimes when you're struggling, there is an elimination or an anti-inflammatory diet you want to start with, then work on gut health and improving your overall health, and then add foods back in. And then if there needs to be a lot of restriction, then sometimes the nightshade vegetables, your onions and garlic and tomatoes and bell peppers and so on can also be problematic for patients with autoimmunity. In the modifications, I do mention microbiome diversity and dysglycemia being blood sugar imbalances. I mention those two because the best thing that you can do for your gut is to have a diverse microbiome, various different bacterial species. And the best way to get that is from diverse plant fibers. So, if you go to the grocery store in the produce section, all the different colors, consuming that gives you the best chance of broad microbial diversity, a good microbiome, which ultimately is one of the best things you can do for your immune system overall. A lot of patients, when they just focus on the restrictions and it's all about what you take out, they don't focus on what to put in. And a lot of times that results in an extremely restrictive diet, and that's really not good for gut health at all, and immune health as well. So, and then patients with Hashimoto's tend to have a higher rate of blood sugar abnormalities. So if you do feel like you're dizzy, faint, lightheaded, shaky, you might be having low blood sugar, and that is very closely correlated with Hashimoto's. And so making sure that the blood sugar control is in a good place is very important. So that's from a dietary perspective. Lifestyle, again, these are the 4 core areas that I try to address as foundations. So diet, stress, sleep, and exercise. So a lot of this I know is intuitive, but it's important to mention that we do have scientific basis for this. We know that studies that show that stress reduction has resulted in lower levels of thyroid function, meaning the thyroid antibody levels, and an overall improvement. And a lot of patients with autoimmunity, when they are in high levels of stress, they really feel that flare coming up. And so they can, whether it's rheumatoid arthritis or any other autoimmune condition. Sleep is very important because poor sleep, even if it's one night, can really impact the immune system negatively and worsen thyroid symptoms and just overall immune balance. Sleep apnea sometimes does increase the risk of autoimmune diseases, particularly Hashimoto's. And then, as we know, physical activity improves so many metabolic functions and overall autoimmune disease outcomes. So these are very important to mention. Some of the supplements that I'll use and that have been very effective. So vitamin D is very important. It's not just a vitamin, but also functions as a hormone. So it's an immune modulator as well. So ensuring that those vitamin D levels are not just bare basics, but higher optimal is important. We have myoinositol, selenium, glutathione, curcumin, resveratrol, amongst several others. But a lot of these are very beneficial for Hashimoto's and just reducing inflammation as a whole. And then you come to thyroid hormone replacement, which is something that many patients need. And there's a certain level to which you can improve your Hashimoto's and hypothyroidism by just using a diet lifestyle first approach. But there comes a time when you might need thyroid hormone replacement. And so this is just generally to tell you that there are a lot of names out there. And what's important to realize is that some of them contain just T4, that hormone, and some of them contain just T3, and some contain a combination of both. Some are synthetic, some are more bioidentical. So there's various different brands out there. I don't think that there's any one particular medication that's the best that you can say always use this, but I think principally it's important to use a combination of T3 and T4. And unfortunately, a lot of times people just get put on levothyroxine and that's just T4, and they don't feel a lot better until you add in T3 adequately. So that's important to know. I also like to speak on low-dose naltrexone. I don't know if a lot of you have heard of low-dose naltrexone. Some people have, obviously, in the health um, field. So naltrexone is this medication that's been around for many decades, and it's very effective for alcohol and opioid addiction. But that is when it's used more conventionally at a certain dosage that's a normal high dosage. What we found in the more alternative or functional medicine world is that when you use this in a micro dose, in about zero 0.5 to 4 milligrams, something like that, it will tend to block the opiate receptors in the brain temporarily, about 3 or 4 hours. And it really helps to reduce inflammation, the inflammatory pathways, and it's even effective for chronic pain. So this is not an opioid medication, it just blocks the opiate receptors temporarily. Um, the reason it's so effective in the addiction part is because it completely curbs the cravings when you take it at the high dose. But it doesn't have the same effect at the low dose. It becomes an entirely different medication. So I've used this to a good success in my Hashimoto's patients and in patients with just autoimmunity in general. And some chronic pain patients like fibromyalgia and those types of conditions can really benefit from low dose naltrexone. It's a compounded medication. It is very well tolerated overall, and it's not very expensive. So that's why I like to use it. If I have to use a prescription, I like to use this as a fairly low risk type of intervention. Now, I do want to address this question about what, we get this all the time. What if my levels are completely normal, but I still have the symptoms of hypothyroidism? You've ruled out iron deficiency, vitamin D, other hormonal imbalances. You've ruled out all these things. But what about if you still have symptoms? You still have extreme fatigue, weight gain, hair loss, menstrual issues, digestive issues, and so on. And I think what's important to understand is that it goes back to my initial point, which is you take the patient and you take the blood work and try to put that together to paint an overall picture. A lot of times what you see in the blood is just a snapshot of the hormones circulating in the blood. It doesn't necessarily reflect how well the hormone is working at the receptor level and impacting the cell and doing its job. And the analogy I like to give is in type 2 diabetics and insulin, where type 2 diabetics, they get insulin, but it's not that they have a shortage of insulin. It's just that the insulin is resistant and it's not working well at the cellular level, which means that then we as physicians give insulin to try and control their blood sugar. So we're just trying to give more of the hormone to try and impact blood sugar and improve that. It's not that they're low on insulin, type 2 diabetics. So in a similar way, you can have normal thyroid hormone levels but still struggle with those symptoms. And so what I try to tell people is that there are certain instances in which I will diagnose someone with hypothyroidism and then put them on thyroid replacement because they need more medication. But there are other instances in which I will use the thyroid hormone replacement for symptom relief. So I tell them, I'm not diagnosing you with hypothyroidism, but I'm using this as a tool to try and improve your symptoms. And a lot of times when we do this, we do get symptomatic improvement. So I want to I want to just mention a few cases that I've had. Obviously, there's so many, but I just picked a few to just so that you understand both these concepts. So W, for just purposes to keep it private, is a 29-year-old female, and these are, again, real patients that are my patients. A 29-year-old female, history of polycystic ovarian syndrome. She came with fatigue, cystic acne, anxiety, depression, bloating, constipation, hair thinning, and weight gain. So all the typical symptoms that we see in these situations. So her blood work, when we do blood work, all normal again. So what do you do in that situation? So again, I'm choosing this case because we worked on all the basics, the foundational stuff, the diet, the lifestyle. She's not like she's coming from eating junk food all the time, relatively healthy, has an exercise regimen, eating overall a clean diet. So we addressed diet, lifestyle, gut health, and some some supplements to improve her symptoms. And she got better, but she absolutely could not lose weight at all. And again, blood work was all normal. So these are the types of situations. And so when you rule everything else out, then the blood work being normal, that's when sometimes you have to use thyroid hormone replacement for symptom relief. So this is the important point that I want to mentioned. So in her case, we used Armour Thyroid, we titrated up towards optimization, and this was after around 18 months of us just trying thing after thing after thing, and she never was able to feel better and had all that resistant weight and all the symptoms I mentioned on the previous slide. And then she finally felt like she got that breakthrough and felt more like herself. So that's important. And then the second case is a case of a 38-year-old female who came to me after having the diagnosis of Graves' disease. Now, Graves' disease is, in a sense, the opposite of Hashimoto's, where it's also an autoimmune condition, but instead of causing hypothyroidism or low thyroid, it's causing high thyroid. And so she came in with Graves' disease. She went to see her primary care, her endocrinologist, all that stuff. She had fatigue, anxiety, depression, PMS, and mood swings, amongst a few other symptoms. And this is what her blood work looked like. So when we got blood work, we could see that, okay, your thyroid hormones are on the high side, where your T4 is definitely high, your TSH is low. So yes, she's hyperthyroid and she's on medication for that. But notice this thyroid peroxidase antibodies that were elevated in her case. And she saw an endocrinologist, and actually these antibodies were much higher back when she saw the endocrinologist. And despite this, nobody told her that she had Hashimoto's. They just assumed that everything that she had was due to Graves'. So the reason I bring this up is because looking at this, you know in about a second that she has elevated thyroid peroxidase antibodies, which means that she has Hashimoto's. And now things like brain fog, fatigue, all of that starts to make sense when you know what Hashimoto's can do to the body as a whole. So she saw her endocrinologist, and she was typically, I don't like to badmouth endocrinologists. My dad is an endocrinologist, so but what I will say is that I think it's fair to call out the deficiencies in the system overall without calling out individuals. So her endocrinologist started her on methimazole, which is to block the thyroid and to improve that, and gave her Lexapro for her anxiety. But again, when she came to me, extremely anxious, not better, very tired, all of those symptoms. So in her case, we treated it like Hashimoto's, which is that we started her on a gluten-free anti-inflammatory diet. We worked on some stress, anxiety relief techniques. We started selenium, liposomal glutathione, some gut immune supplements. We optimized iron, vitamin D. And even before we got to needing thyroid well, she doesn't need it, but even before we got to something like low-dose naltrexone or something else, she was feeling back to her best self, and she was running half marathons, which was one of her goals. So sometimes, and this doesn't apply to all cases, but sometimes if you just have a good strategic plan and a good organized plan, then you can get, in a very short space of time, you can get a lot of health improvements. So those are a couple of cases, which is always good to hear about. So in conclusion, if you have symptoms of hypothyroidism, important to get evaluated. That's pretty obvious. A full thyroid panel should be done when testing to ensure accurate diagnosis. So that goes back to the slide I mentioned earlier, when it shouldn't just be the TSH. It should be all the hormones, and not just thyroid, but everything else as well. Hashimoto's is an autoimmune condition. It's the most common cause of hypothyroidism, and it should always be ruled out. Again, a lot of times it's not done because physicians think, well, even if they have Hashimoto's, how is that going to change management? Whereas, there's so much that I've just given in the past 20 minutes that there can be done for Hashimoto's. We have to take a comprehensive approach. So diet, lifestyle, that is very important. And then thyroid hormone replacement can be used to improve symptoms even if the diagnosis of hypothyroidism isn't present. So this goes back to a core principle of mine, which is about optimization. And so, I hate that word, which is just normal, because when you look at that range with the blood work, that range applies across the board, whether it's a 25-year-old female or a 60-year-old female. And understanding the metabolism of a 25-year-old is going to be different than a 60-year-old. So we can understand the nuance that she should perhaps be higher in the range than that other person. So that's why each person should be looked at individually. What is her level is the same as hers, but one has symptoms, one doesn't. They both need to be treated differently. So I guess I'll stop there. See if you have any questions.